My name is Andy Ustianowski. I'm a consultant in infectious diseases at North Manchester General Hospital, but I'm also the clinical lead for the Greater Manchester Hepatitis C Elimination Programme. Hepatitis C is a virus infection that can cause problems with the liver. It can cause cirrhosis, it can cause liver cancer, and unfortunately it can lead to death. The main risk factor for hepatitis C is acquiring it via needles. Injecting drug use is the predominant risk factor, but it's not the only risk factor. Some people have caught hepatitis C from tattoos, from blood transfusions, in this country before the late 1980s and in other countries still, from sex, and a few other people don't know how they've caught it. It is treatable though. Simple tablets that are well tolerated for 2 to 4 months can eradicate the disease in an individual. And that's let us start thinking about eliminating it as a public health issue in our populations. We have the ability to eliminate hepatitis C as a public health issue in Greater Manchester. In fact, we have aspirations for Greater Manchester to be the first in the UK to eliminate this infection. We've got a distilled programme of how we're going to do it. We have the drugs, tablets for 2 to 4 months that work in about 97–98% of people. So the issue really is making sure that those that are undiagnosed are diagnosed, and those that are diagnosed but not engaged with services become engaged. So the programme involves a bedrock and 5 innovative pillars. The bedrock is really about making sure that what we should be doing, we're doing well. Why are we not testing every single person who attends drug and alcohol services and retesting them every year? Why is the opt-out testing that should be occurring in all the prisons not occurring at 85–95%? Can we use peer support better? Should we be going into homeless hostels, etc.? In terms of the pillars, the first pillar to be activated will be community pharmacies. We're planning for the whole package of care, the whole pathway to occur with community pharmacists within their settings. That'll be the community pharmacists testing people for hepatitis C, providing the treatment, and doing the test of cure 3 months after the treatment finishes. The reason community pharmacies are important are because those patients and those people who have addiction problems, who've used intravenous drugs, who are on opiate substitution therapy, might find it difficult to attend traditional healthcare services, whether primary care, secondary care, drug services, etc., but they do attend their pharmacist regularly. But it's not just that group of people. A lot of the disenfranchised, a lot of the stigmatised people in our communities use community pharmacies as their portal of healthcare and health advice. And therefore some of the footfall coming through community pharmacies is also to be targeted. The second pillar is about network treating. At the moment, someone's diagnosed, they spend a bit of time on a waiting list, they have behavioural interventions to do safe injecting or safe sex or whatever their risk factor is, then they get treated and hopefully cured. Instead, we want to change things around a bit. When someone's diagnosed, we want to incentivise them and their network to come up for testing. That way, we hopefully will improve case finding and find people we wouldn't have found otherwise with this infection. But also, we plan to treat the whole of the network at the same time. So if people don't change their behaviour or fall back to their risk behaviour, hopefully it's to a clean or a cleaner network, and therefore reinfection will be less. The third pillar is about interrogating records, predominantly primary care records. We plan to do this to look for those people that were diagnosed previously but lost to care, but also those people with significant risk factors for hepatitis C. Initially, we'll do this on what we perceive as the important risk factors, but when we have enough data, we plan to use reverse machine learning to work out objective algorithms of predicting those at higher risk of hepatitis C. Those identified will be called up for testing and treatment. The fourth pillar is about prisons. Prisons are very important for hepatitis C. Intravenous drug users frequently end up in prison. It's estimated about 50% during their lifetime, often for very short periods of time. What we plan to do is use point-of-care testing for rapid diagnosis as people enter prison, so-called prison reception. That'll be within the first 24-48 hours of them ending up in prison. We then plan to give them a pan-genotypic regimen, in other words, a tablet which will work regardless of what strain of hepatitis C they have, starting within the next 2 or 3 days. This way we hope that there'll be more testing within the prison setting, but also by starting people on treatment rapidly, we hope to complete their treatment course whilst they're still within the offender health setting. Another advantage of this programme and this pillar in prisons is that actually we hope to have a virus-free prison, and therefore new acquisition of infection in prison, either by injecting or sex, will be decreased. The 5th pillar is actually a reserve pillar, and that's going to be potentially testing all people attending A&E and all new registrants with primary care, or those people undergoing regular health checks with primary care. The reason this is a reserve is it's a lot of testing for a very low yield, and I think we'll be doing it if we need to, depending on the performance of the first 4 pillars. Around all of this has to be informatics. If we're talking about elimination, we need to have better data on where we are now, but also better data on where we are in the future. Added to this is a lot of our planning is based on assumptions and modelling. And as we get data through from this programme, we plan to feed that data back into our models to hopefully refine them and give us a better idea of what's working well, what isn't, what needs extra investment, and actually when certain pillars or certain initiatives have run their course. There's also another factor in terms of informatics. Anecdotally, we have a belief that some people come off drugs, some people come off benefits, some people become more employable by engaging them with care and with interventions such as hepatitis C. What we're hoping to do is join primary care databases and data sets, secondary care data sets, drug services data sets, community pharmacy databases, and possibly social care databases, so we can really provide information on the extra benefits in a health and social care environment of engaging someone with hepatitis C treatment and with hepatitis C care.